All right, let's talk about shock. If you're studying for the NCLEX, you know it's a massive topic. But what if I told you there's a type of shock where the heart is pumping fine, the body has plenty of blood, and yet the patient is still crashing? That, right there, is obstructive shock. And trust me, understanding it is absolutely critical. In this explainer, we're going to break it all down and make it stick. Let's jump in.
If you remember one single thing from this entire breakdown, make it this sentence. Seriously, with obstructive shock, the pump is good and the tank is full. The problem is a physical roadblock, a literal obstruction. Once you get that, everything else just clicks into place.
So, here's our roadmap for today. We're going to start with the absolute basics. Then we'll dive into the three main culprits you are guaranteed to see on your exams. We'll cover how to spot it, what you need to do about it, and then wrap up with some high-yield NCLEX tips and a quick clinical challenge to put it all together.
Okay, so let's lay down the foundation. What is it that really makes obstructive shock so different from all the other types? Nailing this core concept is going to be everything. Let's really break this definition down. I want you to picture a plumbing system. You've got a perfectly good pump, and there's plenty of water in the pipes, but someone's dropped a giant rock in the main line, blocking the flow. That's obstructive shock in a nutshell. The heart is trying, the volume is there, but something physical is just stopping the blood from moving. So this is the domino effect that happens in the body. It all starts with that mechanical blockage. Because of that blockage, less blood can get into the heart to be pumped out. That's your decreased preload. Naturally, if less blood goes in, less blood comes out. So cardiac output and your mean arterial pressure, or MAP, just plummet. The body freaks out and clamps down on all the blood vessels to try and raise the pressure. That's your increased SVR. But it's not enough. The cells aren't getting oxygen, so they switch to their emergency backup fuel, which produces lactic acid, and that leads to a really dangerous situation. Okay, this is a massive NCLEX alert, a huge trap. Your gut instinct when you see low blood pressure might be to slam the patient with fluids, right? But here, that's a huge mistake. It's like trying to solve a traffic jam by adding more cars to the freeway. It just makes the backup worse. Remember, fluids will not remove the physical blockage, and the blockage is the entire problem. So what are these blockages we're talking about? Well, for your exam, you need to know the big three. These are the high-yield culprits that cause obstructive shock. Knowing these is non-negotiable. First up, we have cardiac tamponade. Just imagine the sac that surrounds the heart, the pericardium, filling up with fluid. That fluid literally squeezes the heart like a fist, so it can't expand and fill up with blood between beats. It's basically being strangled from the outside. And how do you spot it? You have to burn Beck's triad into your brain. First, you get hypotension, because a heart that can't fill can't pump. Second, jugular venous distension, or JVD, because all that blood trying to get back to the heart is backing up into the neck veins. And third, muffled heart sounds, because you're literally trying to listen through a layer of fluid. See these three together? You better be thinking cardiac tamponade. Next on our list is a tension pneumothorax. Now, this isn't just your standard collapsed lung. This is way worse. It's like a pressure cooker building up inside the chest. Air gets in but can't get out, and that pressure pushes the heart and all the great vessels over, kinking the vena cava like a garden hose. That completely cuts off blood flow returning to the heart. And what does this look like? Well, your patient is in extreme respiratory distress. When you listen to their chest, you'll hear no breath sounds on the affected side. You'll see that same hypotension in JVD we saw with tamponade. And if it's really bad, you might even see the trachea physically pushed to one side. That's a super late and very, very bad sign. And our third major cause is a massive pulmonary embolism, or a PE. This is when a big blood clot, usually from deep in the legs, breaks off, travels all the way to the lungs, and gets stuck. It acts like a giant dam in the pulmonary artery, completely blocking blood from getting from the right side of the heart to the lungs. The absolute hallmark of a massive PE is how sudden it is. 1 minute the patient might seem okay, and the next they are hit with this wave of severe shortness of breath, sharp chest pain when they breathe, a super fast heart rate, low blood pressure, and their oxygen levels just tank. Okay, so we know the main causes. Now let's put on our detective hats. How do we recognize obstructive shock just by looking at the patient's vitals and all that hemodynamic data? What are the clues? This table tells the whole story. Because of that blockage, preload is down, and so is cardiac output. That makes the MAP drop. The body tries to compensate by jacking up the SVR, which is why the skin gets cool and clammy. But look at that one in bold, JVD. It's present. That's our biggest clue that blood is backing up somewhere. And this right here, this is the absolute money shot. If you see a patient with low blood pressure and bulging neck veins, your brain should be screaming obstruction. This is what separates it from something like hypovolemic shock, where the tank is just empty and the neck veins are flat. Here, the tank is full, it's just blocked. That combination is the key giveaway.
So we figured out what's going on. Now for the most important part. What do we do about it? With obstructive shock, we are in a race against time. We have got to get that blockage out of the way, and we have to do it fast.
This is pure NCLEX gold. You can give meds, you can give a little fluid to try and buy some time, but none of that fixes the root problem. The one and only definitive treatment for obstructive shock is to physically remove the obstruction. That is always, always the #1 priority. So the treatment has to match the cause. If it's cardiac tamponade, you need a pericardiocentesis, a big needle to go in and drain that fluid from around the heart. For a tension pneumo, you need immediate needle decompression to let that trapped air out. Don't wait for a chest x-ray. This has to happen now. And for a massive PE, you're giving high-flow oxygen, starting anticoagulants, and maybe even giving powerful clot-busting drugs called thrombolytics.
All right, let's pull everything together for exam day. We're going to do a rapid-fire review of the things you absolutely must have locked in your brain.
Think of these as your mental shortcuts. First, it's a mechanical problem. Second, fluids are not the fix. Third, that magic combo. JVD plus hypotension means you have to think obstruction. And finally, if you see all of that plus sudden respiratory distress, that is a code red life-threatening emergency.
This little table is going to be your best friend when you're trying to tell the different shock types apart. See how both cardiogenic and obstructive shock can have JVD, but their problems and their treatments are totally different. And look at hypovolemic, no JVD. Use this table to really nail those select all that apply questions.
Okay, you've got all the knowledge, you've got the facts down. Now let's put it to the test with a quick clinical challenge. This is exactly the kind of thinking you'll need for the next generation NCLEX.
So let's put all the pieces of the puzzle together. You've got a trauma patient. They have low blood pressure, a fast heart rate, they can't breathe, their neck veins are bulging, and you hear nothing when you listen to the right side of their chest. What's going on here? And more importantly, what is the single most important life-saving action you need to take right now? Think about it. The answer is everything we just covered. Thanks for joining me.